Good morning, everyone. So welcome to the Virtual International Symposium on Dignified and Compassionate End-of-Life Care, organized by the Action Research for Community Health Laboratory, Arch Lab, of the School of Social Sciences, Nanyang Technological University, Singapore. So my name is Paul, PhD student at the School of Social Sciences, doctoral researcher of the Family Dignity Intervention Research Program, and host for today's webinar. I would first like to acknowledge and express my most sincere thanks to the Ministry of Education Singapore for their generous support with this symposium, as well as the empirical research program on family dignity intervention that aims to strengthen evidence-based and holistic palliative care services within the local context. I'd also like to express my deepest appreciation to the Palliative Care Center for Excellence in Research and Education, PalC Singapore, for hosting the symposium, and also to our plenary speakers for their wonderful scholarly contributions, and to all of you, our participants, for your amazing enthusiasm and interest to this series of webinars that really focuses on understanding and supporting the needs of patients and families facing the many challenges of death, dying, grief, and bereavement. Now, over the next few days, we will hear from and learn from 4 of the most prominent and renowned scientists and clinicians who specialize in dignified and compassionate end-of-life care, research, and practice, all along the continuous trajectory of pre-loss palliative care to post-loss bereavement care. Through knowledge transfer that emphasizes evidence-based practice, as well as opportunities for clinical networking and collaborations, it is our hope that the symposium will create a positive paradigm shift that enhances and augments holistic palliative end-of-life care practices in Singapore, Asia, and of course around the world. So now the virtual symposium is divided into a 5-part live stream interactive webinar featuring 4 distinguished speaker presentations and 1 joint panel discussion spread across 5 continuous days. On each day of the symposium, we will begin with a brief introduction and check-in with our panel speaker. Thereafter, the speaker will present a 70-minute long webinar followed by a 15-minute interactive question and answer session. All participants, that's you guys, are encouraged to post your questions into Q&A window in your Zoom browser. So you will see it at the bottom under Q&A, and you're also able to upvote the questions of your peers by clicking on the thumbs up icon on each of the questions posted. Now, due to time constraints, we'll only be able to answer the most popular questions with the most upvotes as decided by all of you. So please do not miss out on this great opportunity to interact with our speakers and post any questions or reflections that you may have. And we look forward to this segment at the end of today's program. So we are currently at day 2 of the symposium, and I'm most delighted to introduce our second panel speaker, my wonderful mentor, Professor Andy Ho Hao Yen. Hi, Dr. Andy.
Hi, Paul.
Hi. So Dr. Andy Ho is Associate Professor of Psychology and Medicine at the Nanyang Technological University, Singapore. He is the Director of the Action Research for Community Care Laboratory and serves as Board Director for the prestigious International Work Group on Death, Dying, and Bereavement, as well as the Association for Death Education and Counseling. Professor Ho holds a Doctor of Philosophy in Social Work and Thanatology from the University of Hong Kong and a Doctor of Education in Lifelong Learning from the University of Nottingham. Specializing in psychosocial gerontology, palliative and bereavement care, and life and death education, Professor Ho has founded a number of innovative and effective psychosocial spiritual interventions for improving the lives of patients, families, and their caregivers who are facing mortality. Now, these include the Family Dignity Intervention, FDI, for advancing holistic palliative care services, the Narrative E-Writing Intervention, New I, for strengthening pediatric palliative care and parental bereavement support services, as well as the Mindful Compassion Art-Based Therapy, MCAT, for burnout prevention and resilience building among end-of-life caregivers. He has published over 100 top-tier journal articles, books, and chapters, as well as presented at over 180 keynote, plenary, and competitive conference presentations all around the world. In recognition of his social and scholarly contributions, Prof. Ho was awarded the eminent ADAC Academic Educator Award in 2018, the prestigious Nanyang Education Award in 2019 from NTU, and the Distinguished Alumni Award from the University of Hong Kong in 2020. Now, before we move on to his presentation today, I do want to check in with Prof. Ho to see how he's doing in Singapore. So hi, Prof. It's great to see you again, despite our very digital divide. And how have you been doing recently?
It's been as good as it can be. I think we're all under the shadow of COVID-19, although Singapore is coming out of it now with the relaxation of our circuit breaker. But life is not really going back to the way it used to. I think there's a new normal. There is a we're working on a different schedule. We're trying to reduce as much crowd as possible, and also being very vigilant in terms of our health and our public sanity. So it's a different life, but one that I actually enjoy because I actually get to spend more time at home to be with my newborn son, who is now 8 months old.
Oh, wow, that's great. So, Prof, how has this affected your work in palliative and bereavement care in Singapore?
Well, I think it affected my work greatly in terms of being a scientist and a researcher. I work a lot with patients and family caregiver, even professional caregiver. And because of COVID-19, we are no longer able to have access to our patient because we do want to protect them and ensure that they have safety. So access to hospitals and access to nursing homes and healthcare facilities are very much restricted. And so for the past 5 or 6 months since January, we have really been putting a lot of our work on hold. And to really accommodate that, we have to think of really creative ways to continue with our work. So, in qualitative research, we really value the face-to-face connection, but we can no longer do that. So Zoom and Teams has become our go-to meeting places to engage with people and to do interviews with them. So technology has come into play quite a bit. In terms of some of my projects, for example, you mentioned about MCAT, Mindful Compassionate-Based Therapy. We're actually running a series of intervention with advanced dementia caregivers. And we used to meet in groups of 10, 12. We can no longer do that anymore, at least not until the foreseeable future. And so we've been trying to move everything online, really to try and conduct intervention through really well articulated ways of getting them to, because the work that we do is very interactive, is very experiential. And so we have to think of new ways to get them to participate and be actively involved as much as they can using technology. So I think whether or not we can ever get back to the normal that we used to be, I think technology will become an increasingly important part of our lives. And instead of running away from it, I think we have to really harness it and find ways to incorporate it into the work that we do.
So really like a lot of elbow grease as well as ingenuity is involved in this.
For sure.
All right. Okay, so thank you so much, Prof, for sharing this with us. And we'll certainly talk more after your presentation and during the Q&A session. So without further ado, everyone, I would like to pass the stage on to Prof for his presentation of Family Dignity Intervention, FDI, Advancing the Psychosocial Spiritual Domains of Evidence-Based Palliative Care in Singapore. Prof, thank you.
Thank you, Paul. And again, good morning, everyone. It's wonderful to be here, and although I don't get to see your faces, but I'm sure you all look wonderful today. So today I want to spend some time sharing with you the work that we've been doing in Singapore in advancing dignified and holistic palliative care. Before I go there, I need to first of all recognize the wonderful team that I've been working with in Singapore, my co-investigator, including Dr. Ringo Ho, Aileen Hum, as well as Dr. Joseph Carr, who has been wonderfully supportive to the project. We also have a great clinical team, including Geraldine, Catherine, Pingying, and Paul, who was really in the heart and soul of the project because they were really at the front line and providing support to our patients and their family caregiver. So it's an indispensable part of the research team. And I really want to acknowledge our international collaborator, including Professor Hari Chosnoff, as well as Professor Robert Niemeyer, who has been wonderfully helpful and informative and insightful in helping us to develop this program, and also many of our local collaborators. Without them, we wouldn't be able to recruit the patient that we're able to recruit, and this includes Dr. Chompo Heng from HCA Hospice Care, Dr. Anwar Ying from Dover Park Hospice, Dr. Gilbert Fang, and Ms. Tan Yi-ping from the National Cancer Center, Mr. Lok Mark Lin from the Singapore Cancer Society, and Dr. Andy Lee from the Methodist Welfare Services. So as we all know, and according to the World Health Organization, palliative care is really a type of care that provides support and protect people in the most vulnerable state. It is conveyed by words and action that dignity actually resides in people. And I think yesterday, who logged in to our first day of Symposium, I talked about the importance of dignity, how it was actually one of the core defining elements of who we are as a human species, as it was indoctrinated in the Universal Declaration of Human Rights. But the problem with that big word is that we don't know a whole lot about it. We use it all the time, but we don't know what are the constitution of dignity. And because of that, a lot of times we don't know how to improve the lives of a patient apart from focusing on what we know is best, which is medicine. The biomedical model of medicine has advanced greatly over the past number of decades, and we are so much advanced in terms of medical technology, pharmaceutical agents, and so we're really good in symptom control and pain management, but we are very much still focused on that type of mentality, despite the fact that we have called for palliative care to be much more holistic, much more inclusive. We need to provide total care for the whole person. But because of our inability to understand what dignity is or how to provide psychosocial spiritual support, a lot of times we tends to target very much on symptom control and pain management. And when a person is dealing with death and dying, they're not only dealing with pain, physical pain, but they're also dealing with existential pain. They begin to question, why am I here? What's the purpose of meaning? What's the purpose of life? And why am I going through all these suffering? But as healthcare providers, we often don't know what to do. And when we hear patients complain, we often give them more medication, give them more treatment. And this is very much the equivalent of emotional anesthesia, whereby we're really numbing the pain of the patient until death ensues. And I'm quite certain that all of us want to provide dignified care to our patient, and family caregiver wants it, patient wants it. But when we don't know how to provide that type of care, what we usually do is we tend to run away from our patient. Research around the world have consistently found that a lot of times healthcare providers, when they know that the patient is dying, and if they feel like that it is their fault, they feel like they haven't done enough, they tend to run away from the patient and kind of turning into the patient. And we certainly don't want that to happen. We want to be able to understand what our patient's needs are and therefore address it adequately. So yesterday, plenary session, Professor Elizabeth Lobbs have really talked about the work that Harvey has done in Canada, the important work that he has done. I think back in 2002, he did a series of qualitative research looking at what dignity means in the end-of-life context. And he was able to develop an empirical model of dignity that really defined dignity in three major different components. And he talked about the illness-related concern, which is really the physical component of care. When a person's pain is being taken care of, when there's a little symptom distress in terms of psychological distress as well as physical distress, then a person feel a sense of dignity. He also talked about the idea of a dignity conserving repertoire, which is very much a psychological component of dignity, how a person sees him or herself in relationship to his world, in relationship to his family, in relationship to his society. Can he maintain hope and accept the fact that mortality is coming? Can he also engage in dignity conserving practices such as living in the moment and seeking spiritual comfort? The third major dimension of dignity as defined by Harvey is the social dignity inventory. And he talked about this as the social domain of dignity. Can we maintain a sense of privacy even if we're living in institutional care? Can we have adequate social support from all our friends, families, as well as our care provider? One very important element that he also mentioned, as well as Liz also mentioned yesterday, is care tenor. How do we treat our patient? Do we treat them with respect? Do we see them as a person? Or do we see them as nothing more but a series of symptoms and categorization of illnesses? So all these ideas are wonderful, and it really provides a roadmap for us to address and understand what dignity means to patients at the end of life. And from the dignity model, Harvey and his team also developed a dignity therapy, which is very much an integration of logotherapy, narrative therapy, as well as life review, to provide patients with an opportunity to reflect on their lives and build a legacy that's based on meaning, purpose, and hopefully can help them to enhance a sense of dignity as well as quality of life. Multiple international, cross-national studies have really looked at the efficacy as well as the effectiveness of dignity therapy, and repeated research has found that it has been really useful. And so many organizations around the world now see that dignity therapy is an indispensable part of palliative care. That is all well, but the problem with this body of work, or the problem of dignity, is that it is very much a value-laden concept. It's very much a complex idea, and how a person in Western society, which is very much individualistic, and how they see dignity compared to how an Asian person sees dignity in the Asian context, which is much more family-centric, which is much more collectivistic, it could be very different. And therefore, we need to look at dignity in very different light according to the cultural and historical social background. So with that understanding, our team in Hong Kong as well as in Singapore have really dive deep into looking at what dignity means in the Asian context, in the end-of-life care arena. And so we did a series of studies understanding the live and its lived experience of patients and family who are going through terminal illness. And based on our qualitative studies, we're able to generate an Asian model or patient-family model of dignified care. And the reason for us to incorporate this family element is because we know that in Asia, in most Asian society, whether it's Singapore, whether it's China, Taiwan, Hong Kong, wherever you may be, no one really makes any major life decision without consulting their family, whether we like it or not. Well, family will come and consult us, even though we never ask for help. And so whether it is choosing what to study in school, who to marry, or the most important thing, what do we want to live, or how do we want to be treated in the end of life, our family plays a huge role in that. And therefore, when we inquire about the construct of dignity, we also looked at the perspective from the family member as well. So this is the model that we developed in Asia. As we can see, there's two parts of this model. The top part, the pink part, is really what the patients are saying in terms of how to experience dignity. And the bottom blue part is really what the family caregiver are saying. And we found things that are very similar to the Western model. At the same time, there are different manifestations of dignity that are quite different. So let's go in this a little bit more. Sorry about that. So this is the model that I was talking about earlier, about the patient-family model of dignified care, whereby the top part is really about the patient's experience, and the bottom part is the family experience. So we dive deeper into the patient's experience, and what we found amongst patients is that personal autonomy is a really important element of what patient are saying. So this is very similar to what Harvey Chosnow has found in the West, whereby we need to have the sense of control. We need to be able to have a sense of autonomy in our care. But in the Asian context, it's much different. The manifestation of it is rather different because, well, in Western society, it's very much individualistic and people are empowered to say what they want and to be able to obtain the care that they want. Whereas in a parentalistic society like Singapore, even Hong Kong, oftentimes we rely heavily on our healthcare provider to tell us what we need. And so the way that we regain control in our life is quite different. And for Asian in particular, one of the smallest ways that they can engage or regain control is to decide what they want to eat. And this is something that is consistent across our research in different local region. I still remember talking to doing a home visit to an elderly man who was living in a nursing home in Hong Kong. And I was visiting him, and he was living in one of those not so well-run nursing home in Hong Kong, and the living space that he had was really, really small. He lived not in a room, but very much in a cubicle that has a single bed and a cabinet, and that was it. And his cubicle was really at the end of the hall. And I was looking at his living environment, and I asked him, why would he choose this space? And he said, well, you know, I'm on a wheelchair now. I can't really go out, and therefore I want to have a window that I can look outside to it reminds me that I'm still connected to the world. And then I look towards his living environment. I see this cloth hang on top of his bed, and I asked him, why is this cloth here? And he said, well, you know, this nursing home runs on two shifts, the night shift and the morning shift. And when the morning shift comes in, which is about 5 a.m. in the morning, they start turning all the lights on to cook breakfast for everybody. So even if I want to sleep longer, I couldn't. So I asked my son to put this cloth on top of my bed so that the light would not shine directly into my face. And when I sat down, he offered me food, and I was like, oh, you have food? And he had opened his drawer. He has like a whole drawer of snacks and junk food. And I was like, oh, you don't like the food here? And he said, well, the food here is really plain, and the only way for me to regain any sense of control is then I can ask my family and my friends to bring me food every time they come and visit. And so to be able to regain even the smallest amount of control in their daily living, in the food that they choose to eat, becomes a very important element for them to regain a sense of dignity. And contrary to our common belief that older Asian people don't want to know about their prognosis, they don't want to know about the illness, that is simply not true. Elderly patients do want to know what's happening to them. They're very knowledgeable and they're very wise in terms of their body. But oftentimes people don't tell them because they're afraid that it will scare them. A lot of our patients will tell us that, you know, no, tell me what we want, tell me what's happening to me so I can make informed care decision about what I want and what I don't want. I don't want to become a burden to my family. And if I don't make these decisions, my family will have to take on the burden of that decision making, and they don't want it to happen. And a lot of times for our patients, when they're able to make that informed decision and know what's happening to them, once they made the decision, it really relieves their burden. They can really then focus on living rather than worrying about dying. So they're able to plan for the future, whether it is to plan a family trip that they've long wanted to go on but couldn't do so because of work, or to plan for the aftermath concern, what's going to happen to the body, what's going to happen to the legacy. So being able to have that sense of control is equally important in the West as well as in the East. The second dimension that we found in the Asian context on dignity is the idea of family connectedness, which did not illuminate as brightly as it did in the Western study. So what we found is that for Asian elderly patients, they really long for the opportunity to express appreciation. It is not in our culture to be very emotional, expressive, or even verbal expressive. But when we reach the end of life, a lot of these things want to be said. They want to be able to share love. They want to be able to express appreciation. At the same time, they also want to find forgiveness and forgive and achieve reconciliation. I also remember another elderly lady that I did home visit with, and when I reached her home, I was talking to her eldest daughter. And she was completely disengaged. She was not happy. And I was talking to daughter, and the daughter, you know, my mother has not been happy at all. She's sick and she has no energy. And when the daughter left the room, I was able to talk to the patient, and she began to tell me the story that when she was young, she had 6 children, but she was really poor. She doesn't have all the money to take care of everybody. But back in the days, maybe 50, 60 years ago, you can actually sell your child to a wealthy family and get money. And she thought about that. And she actually went and took her eldest daughter and sold it to a wealthy family and got money to look after her entire family. But on the way home, she got so regretful of what she had done. She went immediately back, gave the money back to the wealthy family, and took the daughter back home. And she endured. And she told me why she's so sad and depressed is because after all these years, all the family members, all her daughters and sons have left the family. They migrated, they left home, they have their own family. And now that she's sick, the only person that came back to look after her was her eldest daughter. And every time that she tried to talk to this eldest daughter to seek her forgiveness, she would just brush it away. And therefore, it just goes to show in the last stages of life for Asian families and Asian patients, they really want to find that reconciliation, especially when there are knots that's been tied up for the longest of time. Another thing that was really important in terms of connecting family was that our patient often says that they want to fulfill family obligation. A lot of our elderly patients are also grandparents, and in the Asian context, they want to play a role in their children and grandchildren's life, even to play with them, to cook for them, and to uphold that physical as well as psychological intimacy with every other member of the family. And through doing that, they can also help to strengthen their family bonds, which help reaffirm their identity as well as their roles in the family system. That type of connection then really gives them the sense of dignity. The third category that we found is something that's psychological, but it's also manifested differently from the Western context, and we call it spiritual plasticity. It's really the idea that patients in the Asian context are much more flexible in terms of how they see their lives. One of the most prominent findings that we had talking to multiple patients is that they say, you know what, I know that dying is painful and my disease is painful, but I don't want to be completely numb from my pain, from taking too much medication. Being able to feel pain still reminds me that I'm still alive. And that enduring of pain really helped to strengthen the moral character and spiritual character, even in the last stages of life. And that is not to say that pain management is not important, but we simply cannot numb all of that pain away. The second thing that was really prominent amongst our patients is that they also talked about the fact that, you know, we don't necessarily need to fight all the time. Remember in the Western model, there's an element that calls fighting spirit. That does not emerge prominently in our findings in the Asian context. A lot of the patients said, you know what, being able to let go and to surrender to the natural way of the world helped me to regain a sense of inner peace, even when they're facing mortality. So spiritual surrender was another important element. The third element that really helped to build spiritual strength was the idea of moral transcendence, that patients really want to leave something lasting behind for the loved one. And this is not something monetary. This is not like building a library or leaving a legacy or a fund, but really passing on wisdom and allowing using those wisdom and life lessons and values so that they are able to sustain the family lineage. The fourth part of spiritual plasticity is the notion of transgenerational unity, being able to build relational bond and continuing bond so that they can have the sense of existential wholeness. So that's the patient perspective. And then we also looked at the family perspective. We asked the family caregiver, what was it that was meaningful to you? What was it that you have to do to give you that sense of dignity? And a lot of our family caregivers says, well, they need agency in a sense that they need to have the adequate amount of support in terms of financial support, practical support, even home care services. Those are really important elements of care that help them to cope with the stress and burdens of family caregiving. They also expressed to us that in order for them to get care sometimes in the Asian context, they have to be assertive. They have to be assertive in terms of being able to talk to the caregiver, talk to their professional doctors as well as nurses and social worker about what they wanted. And they need to express that this is the right of my loved one, so please give them that treatment. One other thing they also talked about is that they want to be able to communicate their concerns and participate in care decision making. They don't want to be seen as simply a care recipient. They want to be seen in as an alliance. So this is the first category. So being able to have the financial resources, being able to be assertive in terms of what you want in care, and being able to engage in communicative action is important for a lot of our family caregiver. The second part of the dignity construct in our family caregivers is the idea of mutual support. Being able to have mutual support when, although I'm caring for my patient and my loved one, I still want to be able to have support from them, even if it's a type of psychological support. And this becomes an important element of family integrity. Being able to have that integrity within the family supports the family caregiver to render care. There's also this notion of kinship involvement. We know that in Asian families, we often have a wide extended family and support network. And this is really the time for other family members to step in and provide that type of support when someone in the family is dying. And to be able to be adaptive, to be able to maintain flexibility in caregiving can also really promote integrity and dignity in the face of death and dying. The final category from the caregiver perspective is the idea of filial compassion. And filial piety is a long-standing concept in our cosmology in the Asian context, especially amongst Confucius heritage culture. And filial piety is really the idea that we need to respect our elders. We need to be able to understand what they're going through. We must be able to provide for them. When they tell us to go left, we must not go right. It's always yes and never no. This traditional thinking, although it still remains a critical part of our Asian part of life, but how family caregivers sees that has completely changed. What our family caregivers told us is that they can no longer live by this traditional notion of filial piety, that I cannot disagree with my father or mother. Instead of seeing caregiving as an obligatory duty, what they need to see is that this is a compassionate duty for them. They need to be able to stand in the shoe and step into the world of the loved one and see the world through their eyes, to see what it's like to be suffering from pain, to be suffering from illness. And from that empathetic understanding, they will be much more able to continue with the work of caregiving. I still remember a son who was about 30 years old, and his father was in his late 50s. And he was suffering from late-stage lung cancer, and he decided to quit his job. And before he did that, he actually talked to his wife and say, hey, can you work again? Because I really want to spend the last days with my father and take care of him. And the whole family came together to support the son to leave his job and spend the last 3 months looking after his dad in his final days. And he said, you know, I did this not because I'm obliged to, but because I want to, because I really love my dad, and I want this because I want the best for him. But if I'm driven simply by the obligatory duty and the shame of filial piety, this will not be sustainable. So in that sense, we really need to change the way that we look at these traditional concepts. Are we still driven by the sense of guilt of not repaying our parent death? Or do we want to be changing our perspective to see that I want to do this for my loved one, I want to do this for my elders because I respect them, because I love them? So that's something that's really important. And we also talked about the notion of reciprocal relationship, meaning that despite the fact, yes, you're my father, and you're my mother, and you're my spouse, and I want to look after you, it's not a one-way street. We need to be able to be reciprocal in our support, and that becomes a continuous fuel for family caregivers to continue to do the work that they do. And despite all of these change in perspective, a lot of our family caregiver also express the need to be much more emotional connected to their spouse, to the spouses, to the parent at the final days of life. And that emotional connection allows them to attain a deeper spiritual bond with the loved one. But despite that desire, a lot of them express to us that they don't know how to do this because it is not in their nature to be emotionally expressive. It's often very rare for them to be able to say I love you or even give a hug to a loved one on everyday life. So they need a new way, they need a new platform for them to engage in that dialogue, to engage in that conversation that bring them closer together. So if you look at this model again, you would see that the top part is really the patient perspective, and the bottom part is the family perspective. But it's all connected in the sense that if you look at patient autonomy, when a person wants to have control, they want to be able to make informed care decision and plan for the future, they also sometimes need to have the support and a social agency that the family caregiver have. When a patient wants to be connected to the family, to express appreciation and find reconciliation, to strengthen family bond, they also need to have the family to be intact, to have integrity, whereby everybody is playing a role and everybody is involved. When a patient wants to experience more flexibility, they want to be able to accept death is coming and to be able to pass on the wisdom to the future generation, it also needs the family to have this idea of filial compassion. All of these things are interconnected because we live in this complex web of relationship in the Asian context. And in order for us to really provide dignified care for our patient, we must not just simply focus on the patient themselves. The implication of this model is quite clear. First of all, we need to be able to assess the overall family functioning when we're developing palliative care plan. Although there has been a drive towards person-centered care, I believe we need to move beyond person-centered care towards family-centered care, because we need to look at the family as a unit of life instead of just looking at one individual, particularly in Asian society or society that are collectivistic or family-centric. We also need to appreciate that care decision making, especially at the end of life, is going to be a collaborative process. It's not going to be just talking to the patient, but we need to talk to the family, at least the primary family caregiver, to derive at a decision that is respected by everybody involved. The third thing that's quite clear is that we need to involve family caregiver not as recipients of care, but actual partners in care throughout the illness trajectory into bereavement. We need to empower them with not just practical skills, but also emotional competence to support the dying process and support dying patient living in home and community. We heard too many stories that a lot of our patients want to die at home, and the family member was able to do that, at least for the long duration of time. But once the patient reaches the final stages of life, the family member was not emotionally ready to see the dying process. And what ended up happening tragically is they begin to call the ambulance, and the patient gets shipped from the home to the hospital at the final hours of life. And the most tragic thing that could happen is that the patient do not die in the hospital, nor do they die in home, but they die in the moving car. And while our society and many society are beginning to provide training to family caregiver to support them better to provide care, we must also target not just the hardware, the practical skill, but also the software in terms of emotional competency, emotional readiness to see mortality happening. Finally, we also need to be able to provide an enhanced communication between family, patient, and caregiver beyond this pragmatic focus on physical care. You know, we're very good in terms of caring for someone practically. In the Asian context, the way that we show love is to make food for people, to cook for people. But we also need to know that patient at the last stages of life, food is probably the last thing that's on their mind. Instead of doing those practical tasks, can we provide a platform for them to nurture emotional expression, for them to nurture that sense of personhood, to build up the sense of identity, and also that sense of family, the familyhood that's critically important. And so the implication for dignified death is that we really need to ramp up the holistic component of palliative care policy. What we need to do is, number one, the imperative of patient-family-centered care. Then this involves identifying strength and in developing care partnership with the patient as well as the family as a unit. The second thing that we need to do is to be able to launch advanced care planning, particularly providing patients with the opportunity and the family with the opportunity to make joint decision making about what they want and how they want to be treated at the end of life. And we need to move beyond the simple checkbox exercise, because if you look at a lot of the advanced directive form, especially in the Asian context, even in this country, the form of AMD is only a 2-page document. We need to move beyond that and to include a more continuous, engaging dialogue that is built on trust and built on understanding. And we are moving in the right direction, which is something that's very encouraging to see. The third thing that we need to do is really provide psychosocial spiritual care for patient. We need to move beyond the minimum standards of pain and symptom control to adequately address the total pain within a whole person framework. This idea of total pain came back in the 1960s when Dame Cicely Saunders started the hospice movement. He talked about that pain is not just physical pain, it's psychological, it's social, it's spiritual, and we must need to look at the person as a whole rather than simply looking at them as a series of symptoms. And finally, in order for us to do that, we must be able to enhance the compassionate capacity of end-of-life care worker. We need to instill empathy, kindness, and compassionate delivery of compassion in dignified end-of-life care. So let's focus on this component first. How do we enhance psychosocial spiritual care for patients and family? Well, when the West, when Professor Harvey Chossoff developed the dignity model and he went on to develop dignity therapy, well, we also developed the Asian model of dignified care in the Asian context. And when we identified that family becomes such a critical component of dignity, we also went on to develop something called the Family Dignity Intervention, FDI. And the idea of this is really to provide an open platform for patients and family caregiver to come together, to engage in conversation, to engage in sharing of experiences so that they can build the sense of family connectedness and to cultivate a sense of filial compassion, to see each other's perspective, to understand each other more, and to appreciate each other more. And this platform provides the opportunity for them to express love and find reconciliation, to build family bonds, as well as to solidify and to pass on transcendental wisdom and life lessons that can really help sustain the family lineage and for building a lasting legacy. And so when we looked at the dignity therapy is really about the patient and the therapist, the connection between them. And within this relationship, we focus on care tenor. We focus on treating the patient as an individual. We provide them with support. We create this opportunity for them to feel generativity and for them to feel hope and role preservation. In FDI, we do all of this, but we engage the family member in there as well. And we want to emphasize the notion of expressing appreciation, to achieve reconciliation, to provide this platform for them to build bonds, as well as to pass on wisdom and value. So FDI is really then an evidence-based, family-centered approach for dignity enhancement. This is what the family FDI protocol would look like. Similar to dignity therapy, it's a 4-session, very much a 4-session intervention, because we know that a lot of our patients don't have a lot of time, and time is of the essence for them. We cannot engage them in long-term psychotherapy, but we need to be able to provide something that's brief, structured, strength-based, and they can potentially find meaning in the way that they live the life. And so this is a 4-session. The first session is really a screening session or a framing interview. We meet the patient and the family for the first time, and we give them a set of questions that we'll be asking them, and we get them some time to think about them, and we also ask them, we're going to develop a legacy document for you. Who do you want to dedicate this legacy document to? So they have some time to think about the response, and the next week we come back, or the next time we come back, we then engage them in a 60 to 90 minute long family dignity interview, a structured interview, a semi-structured interview that dives into and explore different areas of their life. And once that interview is completed, it's audibly recorded, we transcribe it very quickly, and then we put it into a preliminary legacy document that tells the life of the patient. We meet them for a third time, and we show them the document. We show them this is what we came up with. Is there anything that you want to add? Is there anything you want to remove? As long as this is comfortable for you and you like it, then we go and finalize it. But our intervention do not end there. We meet them for a final time. And this is when our therapists actually help them to arrange a family meeting. And we get everybody to come together in an environment, and the therapist read out loud the entire legacy document of the patient's life, not only to the patient, but the entire family. And this experience can be healing, this experience can be cathartic, and this experience can uplift the spiritual existential wellness of the patient as well as the entire family. And so the interviewing schedule is just simply 12 questions. Obviously, we do expand beyond these 12 questions because we probe, we go deeper, but this 12 questions provide us with a framework of what to look out for. And so if you look at some of these questions, we're really looking at certain areas, certain memories that was really important to the patient, a life history that was most important, most memorable to you. We talk about the relationship with the loved one. How has he or her influenced your life, and vice versa? What do you want your loved one to know about you or remember you by? What are some of the most important accomplishments that you have in your life, whether it's your family, your career, or in terms of your community? What do you think your loved one is most proud of you or appreciative of you? And how do you appreciate your loved one? Are there particular things that you would like to ask forgiveness for or give forgiveness? Are there teachings and words of wisdom or advice that you want to pass on to your future generation? What are your hopes and your dreams for your loved one? And are there anything else that you want to include? And I think Liz talked about this quite importantly yesterday, is that we don't just simply follow this 12th question. Yes, it is a very important framework, but we also need to be able to have that curiosity, that compassionate awareness and presence to encourage people to speak up. And while the question is directed to the patient, we also engage the family member and ask for their perspective as well, because that will allow the dialogue to flow. It will also allow the expression of appreciation and reconciliation to happen right within the session of the FDI interview. And that can be healing in itself. And so as a scientist, we often want to develop something that's useful and we think it's useful, but we don't know. And therefore, we need to be able to engage in one of the gold standard of evaluation is to engage them in a randomized control trial to test the effectiveness of FDI, to see if it's actually useful to uplift the wellness of patient, psychological wellness, as well as the psychological wellness of the family caregiver. So over the past 3 years, we have done a lot of work in doing this, in running this randomized control trial. This is a 2-arm open-label randomized control trial. We have a control group which received normal psychosocial care, and then we have an intervention group who received the 4-week FDI intervention. And the hypothesis is that those who received the intervention FDI would do better, significantly better than those who did not. So we were able to have the wonderful support of our collaborators, including HCA Hospice Care, Dover Hospice, Tan Tock Seng Hospital, the Singapore Cancer Society, as well as the Methodist Welfare Services, to recruit 91 families to come to our study. In fact, there was a lot more families that was recruited. More than 200 families was referred to us. But because of the dire situation that the patients were at and how their disease progressed, deteriorated very fast and very progressively, by the time that we reached these patients, they were not ready or no longer available to engage in this intervention. And it further goes to show that if we want to engage patients at the last days of life and provide them with psychosocial support, it needs to be brief, it needs to be fast, it needs to be something that can be achievable within a short period of time. So with this sampling frame, this is really the procedure of our RCT. We were able to, first of all, screen the patient to make sure that they are able to engage in a conversation about their lives, and and they pass through the screening. And once they are referred to the team, we engage them in a baseline assessment to test them on a series of psychometric batteries. And then we randomize them into either intervention group or a control group. And for the intervention group, we meet them for the 4th session, the first framing interview, and then we went into the full FDI interview, and then we transcribe them, we share them with our edited document, and then we meet them for the last time to share it with the entire family. And after that, we assess the 2 groups again. We assess them a 3rd time 1 week later, and we also are still in the process of waiting for a bereavement outcome because we want to see whether FDI could be useful in preventing adverse grief impact. And so these are some of the measures that we had. We measured patients in terms of the dignity. We measured them on the depression, their sense of meaning, the quality of life, their spirituality, their hope, as well as their social support. For the caregiver, we measured the same thing, but we also added the elements of caregiver stress and burden, as well as post-bereavement outcome. And this is only for once the patient has passed away. So we have really mostly completed our RCT, and we were able to run the full spectrum of data analysis with 182 participants, with 45 caregiver and patients in the intervention group and 46 patients and caregiver in the control group. Because of the skewness of our data, we were not able to run parametric tests. So we have to run non-parametric tests, including man-weighted U tests, as well as with constant sign tests. We also looked at the effect size. So when you look at research, we need to know that it's effective in terms of it's significant, but we also need to look at the magnitude of change. How impactful is this intervention? And when we look at the effect size using R, we know that anything from 0.1 to 0.2 is good, is small. Anything from 0.3 to 0.4 is medium. Anything above 0.5 is large. So when we look at the significance of our findings, we also want to look at the magnitude of how much change that this intervention can bring. So what did we find? Well, first of all, this is the demographics. We have most of our patients are around the age of 69 years old, and our caregiver around the age of 55. Most of our patients are male, and most of our caregiver are female, which reflect quite well what the Asian context do look like. In terms of the relationship between the patient and the family caregiver, most of them are spousal relationship, and the majority of them are also parent and children. In terms of the type of illness that our patient had, cancer, 92%, and then following by non-cancer such as end-stage disease or renal failure. So what did we find? Well, this is a between group comparison, comparing FDI patient as well as control. And we looked at, first of all, quality of life. And indeed, we found that people who went through the FDI intervention, they experienced significant increase in quality of life immediately after intervention, 7.6% higher than the control group, as well as 1 week later, 9.3% higher. So this goes to show that not only is FDI immediately impactful, but it's also clinically sustainable. It has a long-term lasting maintenance effect. When we look at hope, we also found that our patient experienced higher level of hope immediately after the intervention at 7.5% higher, as well as 1 week later, which is at 10.1%. And we look at the effect size, we range anything from 0.26 to 0.31, a medium effect size that is usually higher than what most psychotherapy offer, which is a low effect size. We also looked at different elements of hope. So can a patient have a presence of goal? Can they still look at the life with goals and have a positive outlook towards life? And definitely we do. We found that our patient experienced this idea of seeing the life of value and goal at T3, with an effect size of 0.264 and a difference between 11.8%. We also are able to see that patients are able to recall joyful time and see that the life have value, with an effect size of 0.321 and 0.341 1 week and immediately after the intervention. In terms of spiritual well-being, our patient also experienced an elevated sense of meaning in life, 23% more than control group immediately after the intervention, and 27% more 1 week later. In terms of their sense of perceived support, again, we see our patients feeling a lot more supported in their end-of-life experiences compared to control group, 17% more and 13% more 1 week later. In terms of family caregiver, one of the most significant findings that we had is we found that our family caregiver who went through FDI experienced significant reduction in caregiver stress 1 week after the intervention, 20% less than the people in the control group, and with an effect size of 0.224. In terms of depressive symptom, our family caregiver also experienced significantly lower depressive symptom immediately after the intervention, 62% lower, and 61% lower 1 week later. We also found they were also able to experience higher level of hope, 6.5% higher immediately after the intervention, as well as having the ability to see that the life have value, that they're able to recall joyful time at T2, at T3 for our family caregiver. We're also able to, one thing that we also able to achieve and found is that for our family caregiver, when we look at them across time, they were able to begin to make meaning of their experience after going through the FDI, despite knowing that the death for their loved one is coming, an increase of 16% from baseline. Apart from the statistics, which doesn't lie, we also asked for our patient and our caregiver, what was it like for you to go through the FDI? And a lot of them said, well, this is actually very important. 85% of them identify FDI as equally important as any other element of the medical care. 85% believe the same is important for the medical care. 80% of patients and family caregivers find it to be helpful in terms of improving the quality of life, lessening the burden, make them feel valued and worthwhile. They find life to be more meaningful and enhance a sense of dignity. More than 70% of our participants believe that FDI helped them to finish unfinished business. It helped them to have a greater control over their life, enhance a sense of purpose, and reduce the sense of suffering. And directly from the words of our patient and caregiver, this is what they have to say about the intervention. When a male patient said that, for the very first time in my life, I feel like somebody really understands me, like someone sat down and asked me all these questions, nobody that ever asked me before, and they really listened. It felt really good. Another female patient said, normally my caregiver wouldn't say I love you to me. She rarely said that to me. However, when she said I love you to me during the FDI interview, I could really feel that she meant it. Another male patient said, I felt wonderful when I listened to my legacy document because I was able to reminisce about my past accomplishment and achievement that I'm proud of. Oftentimes, what do we usually say to our patient when we see them for the first time or every other time? We ask them, have you taken your medication? Have you passed movement? But have we ever asked them who they are and how they're doing as an individual? Our caregiver also expressed what they feel about FDI. And one husband caregiver says that at times there are things that are not shared and we would not know what was going on. Now that we know through FDI, we have a deeper understanding of each other's perspective. A caregiving son said that the last time I won't even sit down and talk to my dad. But ever since the FDI interview, I read out what you guys gave me, the legacy document. He smiled and he was quite happy about it. It brings me closer to my dad. And finally, for the first time, I saw the love of my father. A son-in-law said, to me, it was quite a pleasure to hear the patient's story. Before this, I don't know anything about him, like a legacy that we can actually bring forward to our next generation to show them that the great-great-great-grandfather, who he is, the kind of person that he is. This is evidence to show where your ancestors are from. The clinical implication of this is quite clear. FDI shows that it is very much effective in improving the quality of life and hope and meaning, and shows the support of patients as well as caregiver. Patients are able to record joyful memory and experience greater sense of hope, meaning, and purpose, despite the fact that they're faced with the many challenges of mortality. In terms of caregiver, they're able to accept and find meaning in their loved one's impending death and experience greater joy, reduce caregiver stress, as well as depressive symptom in the midst of the grief. FDI, we're quite proud that it's been shown that it's quite capable of addressing the psychosocial spiritual needs of terminal patients and family, and complement existing palliative care service provision by realizing the aspiration of whole person care, moving beyond the physical element and tapping into the psychosocial spiritual domain of care. And I also believe that FDI can very well augment advanced care planning. Now, 2 years ago, we did a national evaluation of the Singapore Living Matter program. And one of the things that we found is that patient and family caregiver are often not ready to engage in a dialogue about care, but they're very ready to engage in a dialogue about their life. And throughout the FDI interview and throughout our experience for the past 3 years, although we're talking about the life of the patient, the notion of death will eventually come out. Because we asked about what do you want? What do you want your family to know about you? What do you want? What are your dreams and aspirations for them? And they will eventually talk about what they want for the end of life care. And if we can include FDI as a prelude to advanced care planning, let's talk about you as a person first. Let's understand you as a family before diving into your medical decision. I think this will work wonderfully together as a prelude to ACP. But despite the robustness and the clinical sustainability of FDI, we need to understand that any therapy is only as good as the people who are providing it. I still remember presenting this presentation, or at least the preliminary findings of this, in the Asian Pacific Hospice Conference a year ago in Surabaya. And at the end of the presentation, one of the questions from the audience was, Andy, this is wonderful findings, but it seems like that a lot of your outcome based on who is actually providing care, and that speaker or that person asking the question cannot be more right. Definitely. The person who is providing care, who is running the intervention, becomes the critical component to make this intervention work. And this goes on to show that we need to be able to instill compassion and empathy into the delivery of care. Right? It's not just simply going up to a patient and say, hey, of course I'm listening to your expression and I'm listening to your spiritual suffering. Don't you see me making eye contact, stroking a open posture and leaning towards you and nodding empathetically? That is just the basic of what we need to do behaviorally, but we need to change intrinsically how we see life inside to be able to step into the shoe of our patient and to see the world through their eyes so as to understand their pain and their suffering with this desire to alleviate their pain. And that's where true compassion comes into play. If you look at different religious writing and scripture, the unifying thread that connects all of them is the idea of compassion. It's really simply the awareness of suffering of other species and other creatures, and also have this concern to alleviate that suffering. We first of all need to distinguish between empathy and compassion, because these two words are often used interchangeably, but they're two different constructs. Empathy is really just a heightened, well, it's really about being able to step into the shoe of the other person and experience the world as if something to be understood. But empathy alone do not bring about compassionate action. Compassion built upon empathy, and by recognizing what is happening to a person's world, by recognizing that suffering is happening, we have this innate desire to alleviate it. Empathy then is really a part of compassion, but by itself does not lead to compassionate action. Compassion involves our empathetic capacity to recognize that suffering is happening, to not just recognize that it's suffering, to be able to stay with and be with suffering, and be motivated to alleviate suffering either through just an engaged presence, because at the end of life, a lot of times there's nothing much we can do. Just by having our presence, that can be compassionate act, or by witnessing, or by doing something about it. Now that we know that compassion is really about recognizing suffering, then what is suffering? Well, suffering comes in many different shapes and forms. Being able to not see goodness in myself, that's suffering. To be suffering from a chronic illness, that's suffering. To dropping my iPhone onto the cement floor, that's suffering, because it costs a lot of money. But there are ways that we can overcome these suffering, but there's also ways to help us get stuck into these suffering. And there's one story that I want to share with you. And this is a story that comes from a Buddhist philosophy. Although I'm not a Buddhist or I'm not akin to any religious faith, I do read these Buddhist scripture. And this one story really stuck with me. So there are these two families who are experiencing the same tragedy. The house got burned down, and this disciple of the Buddha saw what happened to the two families, and he saw that one family was able to cope with the tragedy quite well. They're already building the next home. They're planning on to recover, and the other family is just constantly in a state of despair. They're sad. They're distraught. They couldn't believe that this is happening to them, and they feel like, oh my God, my whole life savings is burned down. And the disciple went to the Buddha and asked, why is this so different? Why are these two families facing the same tragedy and the reaction towards it so different? And the Buddha said, well, there are all these arrows that we get hit at in our life, and we cannot escape from them. And these arrows are arrows of suffering. And he said that there are 8 different sufferings in life. The one suffering is birth. Birth is great suffering to mothers, and I can attest to that, because we just gave birth to a beautiful son, and my wife went through a lot of pain carrying the child. Old age is suffering. I mean, look at all the products that we have in the world to prevent us from getting the wrinkles. We don't want to grow old. That's suffering. Illness is, of course, suffering. Death is suffering because it breaks relationship apart. Hatred is suffering too. To love is also suffering. While the act of love and you're with someone can be euphoric, but at the same time, once the person leaves us, it's suffering because we believe that attachment is gone. Our desire for things is suffering, and the things that give us pleasure is also suffering. And the notion for that suffering is because we hold on to these things that we believe to be permanent. We believe them to be forever, but in fact they're not. And once we realize that they're not forever and things is going to change, it's going to bring us suffering. And the Buddha said that there's no way to run away from these things. These are the arrows that we get shot at us without us realizing. But some of us can just receive the first arrow and try to overcome the suffering. But for many of us, the moment we get hit by the first arrow, we shoot ourselves with a second arrow by asking, why does this happen to me? Why do I get sick when I never smoke a pack of cigarettes or smoke a cigarette in my day, and my neighbor runs marathon and he smokes a pack a day? This type of negative reaction towards the tragedies in the life, towards the adversity in the life, becomes the second arrow that gives us a greater deal of pain and suffering. And so in order for us to alleviate that suffering, in order for us to recognize suffering is happening, something needs to happen. We need to be mindful of what we do, to be able to be fully present in the moment, be with the other person, and notice what's happening here without judgment and without aversion. And once we're able to do that, intrinsically kindness do emerge. We do have this intrinsic desire to alleviate suffering from happening. We want to treat others well. We want to be able to soothe and comfort them when they're going through pain. And when we're able to do this, the third thing transpiring in compassion is this notion of common humanity. We begin to see that we're not alone, that your pain and my pain are very much similar, although it is unique in its own way. And everyone will eventually die. And therefore, if I know that I'm going to die, and I know that you're dying, I want to be able to, I want you to experience wellness and existential wholeness in the face of mortality. Because I know too that one day I'll be at the same place as you are. And that drives us to do more, to provide comfort to other people. We often think of compassion as something that's an outward experience, but it can also be an inward experience. Because if we don't know how to love, how could we expect someone to love back? It's really about taking care of ourselves and recognizing what is happening inside of us, to be able to be comfortable and content with our own sense of inadequacy, and to be able to recognize our own pain and recognize our own limitation, and to be kind to ourselves so that we feel supported, and then we can be kind to other people as well. Self-compassion is always available. It fosters connectedness rather than self-centeredness. It cultivates authenticity in our relationship with others people, and it can transform suffering into opportunity for kindness and connectedness. And the good thing about compassion is that it's something that can be taught and mastered through contemplative practices. And there are many different practices that we can engage in, but mindfulness meditation is something that it's easy to do. And we can all, do it in our own time. And if we break it further down, mindfulness is really about paying attention to the present moment without judgment or resistance. The first part is already hard enough. The second part is even harder, because as a young child, we're often taught to judge whether this is a dangerous situation or not. But when we're working with someone who is vulnerable, when we're working with a patient, we don't get to choose how a patient are. And therefore, we need to be able to suspend our judgment and treat everyone the same, and paying attention to this very moment. And this picture really encapsulates the difference between a mind filled with rubbish and a mind filled with clarity. As human beings, we're often sitting in one place and we're thinking about the future or worrying about the past. Whereas an animal or a dog, for those of you who pet at home, if you study them long enough, you realize that they're very mindful. This is my dog. His name is Bo, and he is a wonderful creature. When you scroll him when he did something wrong, he will have very sad puppy eyes, and he would be very tremendously devastated. Once you're not mad at him anymore, his will change immediately. He will come running to you, licking your face and wanting to play with you. And this is the difference between human being and other species. Human beings are always bombarded with different thoughts running through our mind, whereas other species, or even young child, they're completely present with you. But when our mind is not fully here, we lose our mind in the midst of therapy and treatment, and we lose our humanity in the midst of therapeutic tools. We focus so much on treatment, we focus so much on symptoms, we forget about the person. And when we're not fully mindful, it's the greatest travesty in life, because we see without knowing, we hear without listening, we eat without tasting. And for all Singaporeans out there, you eat and you don't taste your food. Isn't that the worst thing that you can experience in your life? We touch without feeling and we speak without connecting. And even on Thanksgiving Day, when everybody comes back home, it is only the dogs that realize that everybody is here and they're able to appreciate the present moment. The umbrella of mindfulness builds upon one another. First, we need to be able to pay attention to what's happening here and relate to the experience without running away or judgment or resistance, and that's mindfulness. And once we're able to do that, we can then relate to the experiencer with the desire to alleviate suffering, and that's where compassion shines through. And once we're able to do that, the next step is to cultivate wisdom, to be able to distinguish between the experience and the experiencer, to know that I am here to offer help. And if whatever I've done, I know that I've done my best. And if it's not helping, it's not my fault, but it's just a fact of life. The mortality is real. These four aspects accumulate and build upon one another. And the more we practice this, the more we can connect ourselves better and connect with other people. Mindfulness is really about paying attention to what we're doing and have the clear intention of why we're doing it and bringing the right attitudes towards the behavior that we have. And this is something that I think is not a luxury, it's not an option, it's something that's critical. It's an ethical conduct that we must bring into our clinical practice, because our most primary objective as health and social care professional is to do no harm and to bring wellness to our patient. But if we're not fully there, we will run into danger of not having clarity, to be completely reactive and to be not in the present moment. But if we're mindful, we can very much listen differently and listen to lives and what our patients' needs. We can attend to people's experiences with observation, with ability to let go of our assumption. We can also maintain a degree of humility to learn and be curious towards other people's experiences. And that allows us to discover what would serve best in different circumstances. We're able to let go of our own self-interest and have the courage to engage in action to preserve integrity in the work that we do. And I think in end-of-life care, there is nothing more important than integrity or anything else, especially in times when we have to deal with this moral distress, when we're asked to do something that we think is not right, when we're asked to give more medication, when we know that medication is going to do harm to this patient. And mindfulness allows us to stand up and say, hey, no, this is wrong, and we must preserve that type of integrity. And being mindful also allows us to really understand and be curious towards the life of our patient when we engage them in FDI. We need to show that compassionate presence. We need to be able to understand what's going on. We need to be able to listen deeply and connect with our patient to make FDI an effective intervention. You can have the greatest intervention in the world, but if you have the wrong person doing it, then anything else would go to waste. Research around the world has shown that the more that we practice in these reflective engagement, the more we're able to regulate our emotion. In fact, research has shown that we engage in meditation long enough, areas in our prefrontal cortex as well as our right interior insula, the gray matter around that region that controls emotion actually grows bigger. The gray matter grows bigger. Not only does it have a change in our brain structure, mindfulness meditation is really about having this presence of here and now. This is the word for thought in Chinese character. If you look at the top part of this, is about nian, which means here. And the bottom part is xing, heart. To be mindful is to be here, now, mind, body, heart, and soul. And that's exactly what our patient needs from us. And to practice in mindfulness in our everyday life, we can walk and enjoy the gardens, enjoy the scenery. We can eat by really chewing and tasting our food. We can wash our hands and realize that we have running water coming through our faucets. If we have mindful, intrusive thoughts that are coming into our mind, we can stop and not allow them to attach to us. And we have unwholesome emotion. We can begin to say, stop, let's start a new day with a new set of attitudes. I know we are running out of time, and I did want to do a meditation with all of you together, but it seems like it's not very possible. But I think one thing that I do want to end with is that life is just filled with little moments, moments of triumph, moments of happiness, moments of sadness, moments of love, moments of forgiveness. And if we're not fully there, if we're not compassionate, if we're not aware, all of these moments would run away. It will skip us by. And for a patient whose time is running short, all of these single moments become even more pronounced and even more important. As health and social care provider, we must grab onto these moments and to be able to share them and enjoy them with our patient, and to really truly realize the idea of total pain, whole person care, and providing them with psychosocial spiritual support in their final days of life. The Dalai Lama says that love and compassion are necessity, not luxury. Without them, humanities would not survive. I would finally like to thank the Ministry of Health, Ministry of Education, the Academic Research Fund for generously supporting this project. And that is my presentation.
Okay, thank you so much, Prof. Ho, for such a wonderful and such an insightful presentation. We've had so many wonderful comments coming in, saying thank you for the work that you've done, enunciating how important FDI is to the local context as well. Okay, so in that vein, will you be open to taking some questions, Prof?
Of course.
Okay, all right. Okay, so to everyone, all the attendees, please do note that we'll only be answering the kind of like the most popular top voted questions. So please do your voting currently. So because we do have time constraint as well. Thank you so much for understanding. Okay, so Prof, we have a question from Aaron. So Aaron states, Prof, would you like to comment on the intergenerational differences and perhaps the therefore differing attitudes between the patient, who might be from an older generation, and the caregiver, the child, or maybe like someone from the younger generation, vis-a-vis the caregiver having a bit more of a Western influence?
Mm-hmm. I think this is something that we cannot escape from. I think as society evolve, when the world become much more globalized, a lot of our traditional thinking do not hold grounds anymore. I mean, if you ask me today to take care of my parent just because I'm obliged to, because I own them, because I'm in debt to them, this will not fly. Yeah, this is not going to happen. And I think whether you're a young generation and an old generation, we need to be able to take a much more humanistic approach to understanding life. Instead of we expecting our children to take care of us, we also need to think, what can we do and support our children in such difficult times? How can we support each other in the face of mortality instead of just relying on one party to do most of the work? And I think a lot of that comes into open communication. We rarely talk about our feelings. We really, even though we may not agree with our parents, because out of respect and out of fear that they will deject us, we don't say it out loud. And sometimes saying out loud is not disrespectful. I think saying out loud is actually a respectful act, to be able to openly and respectfully share what's happening within your thinking and within your life, that actually create more understanding and more appreciation between both parties. And I believe that people are malleable, people are decaying change, and if you're honest and have gratitude towards them, they're willing to listen. And I think our older generations are wonderful people. I've worked with a lot of them. They're very open-minded, and I think sometimes it's really whether the adult children generation is ready to take on that step further, to engage in that dialogue.
Wonderful. So thank you so much for sharing that, Prof. Okay, so we do have a question from Joyce, and Joyce asks, do you have any experience working with patients or caregivers who were in denial about the prognosis? And how might you help them to overcome this denial to then facilitate an FDI session?
Well, one thing that I do want to highlight is that FDI doesn't really talk about death. So when we introduced FDI to our patient, it's really about an opportunity for us to learn more about you. We want to provide you or to offer you a chance to reflect on your life and to support you in a way that helps you build a legacy document. It's really about talking about what you have accomplished, your relationship. So we're not really going in to talk about death. And it's important for us to realize that some patients, especially in Singapore and Asia, a lot of them may not know their prognosis because their family, yes, they do want to, in that sense, protect them from the news. So we have to tread carefully when we're doing intervention. We want to make sure that we have substantial information about the family, about the patient, and we don't bring out death, the topic of death, in our conversation. It is only when the patient brings it out then we engage in a conversation about it. And we also don't engage in them with ACP immediately because we're not trained in that sense. So when we say that these ACP and FDI can be incorporated, we do want to make sure we have the right people in place doing the right thing. So we may have an FDI therapist who goes in and works with a family and the issue of death comes up. And then we ask for permission and say, hey, since this is so important to you, can I refer someone to talk to about these issues? And oftentimes they will say, great, we can talk about this. And we also need to realize that although patient may not know exactly about their prognosis, but our patients are very smart. They know what's happening to the body. And when something is wrong, they often have the desire to know more about it. And so the topic of death often comes up in an FDI session, and it's okay to discuss it. And through that discussion and through that dialogue, the family caregiver will also get a better sense of what their loved one is going through, and perhaps they would be able to feel more comfortable allowing them or letting them know that information.
So if I'm hearing you correctly, Prof, so you're saying that a lot of times this conversation, this topic of death and dying comes out organically through FDI.
Very much so. Yeah, instead of us raising it, it comes organically. I mean, when we talk about, what have your accomplishments like, when we talk about what do you want to leave behind for your loved one, what is some wisdom you want to pass behind, it will just eventually comes up. 80–90% of the time, we don't have to mention the word death, and it just appears.
Okay, thank you so much, Prof. Okay, so we actually have a question from Dan. So Dan, So Dan says, how can we strengthen the dignity of our elder patients as they go through the decline of their mobility and health? So perhaps I think he's talking a little bit about like anticipatory grief here. So slowly, all the losses that are slowly shoring up towards the end of life.
Right, that's a great question, because the inevitable part of illness and the dying trajectory is progressively we will lose our functional capacity. You know, some of us may not be able to put our own clothes, to brush our own teeth, and then we have to become increasingly dependent on the person, and that can be very debilitating, and it can also lead to a lowering sense of dignity for a lot of our patients. But the good thing is that we know that dignity is multifaceted. It's not just simply about our physical capacity, but it's also about the way that we look at life, the way that we look at ourselves in relationship to our lives. So while some patients may not be able to be as active as previously, some of our patients love to cook. They're great cooks and they have all these great recipes. They may not be able to produce the food anymore, but they have the capacity to pass on these knowledge to their children and teach their children how to cook this food, how to continue this recipe. And once they're able to see that my life and my wisdom and my thinking or my value get imprinted onto my loved one and my family, this then rejuvenate their sense of dignity. So their dignity then become manifested in different ways. While yes, I'm losing my functional capacity, I'm less mobile, but I can also focus on other elements and other dimensions of my life, to focus on my relationship, to focus on my own personal growth, to focus on the things that give me purpose and meaning. So it further goes to show the importance of empirical research, to work in an evidence-based environment, to really be informed by research, to understand what our patient is going through, and that give us different avenues and different channels to come in and support a patient who is going through illness and mortality.
So really the sensitivity of the FDI therapist as well is something that is of utmost importance, you would say.
For sure. I think the FDI therapist needs to be able to have that sensitivity, that awareness, and the mindfulness of what's actually happening to the patient. And again, I can't stress enough that it's, while we have a 12-question interviewing schedule, it's really not just that 12 question. We cannot simply jump from one question to the next. We need to ask the opening question and listen to what the patient have to say to us, and respond in a way that it shows, at least the patient can feel that you're actually interested in their lives. And it's not just you're putting up a front, you're genuinely interested in their lives. And then you want to find out more. You want to understand what's defining of them. You want to find out what gives them meaning, what gives them happiness. When we are able to engage them in that human level and move beyond just the question and really engage in a conversation, it itself can be very dignifying.
Okay, thank you so much for the answer, Prof. So we have a question from Pei-Ling To, who asks, the dignity care model developed for our local context is very encompassing and insightful. She does ask, would you be able to share 2 key challenges in implementing the model or the therapy work?
Well, I guess one of the challenges in the model is that I think in Asian contexts and in Singapore, there is still a very much top-down approach to medical care. So, there is still, in not just in FDI research, not on dignity research, but just looking at palliative care research, we see that there is still a very strong sense of system hierarchy. There is different position within the healthcare system, different people have different power. And while we strive towards interdisciplinary teamwork, which really is important, that's what Liz talked about yesterday, there is this process, but within the process of interdisciplinary teamwork, there is still a power differential within them. So just envision yourself going to a team meeting. There's your physician, there's your social worker, and there's your nurse, and there's your volunteer, there's your OT or PT. Think about the last meeting that you had. Who are the one that has the most power in that conversation? And is everyone's viewpoint being valued and being respected? And I think that's one challenge. And there's also the challenge that family caregiver talked about too, is being able to express what they really need to be able to be assertive and to be informed about care. Which goes on from then is that, can we really cultivate that sense of care partnership? Do we see our patient as just simply recipients of care, or do we see them as people of strength and power that they can be they can be empowered to do more? Can we actually can we see our family caregiver as allies than just simply someone who is constantly receiving support from us? Because if we can empower family caregiver, they do more of our work, and they can do it even better because they know the patient. In terms of implementing FDI, I think one of the biggest challenges that we face so far is getting people to buy into it, because it's something new. And it's also it can be quite time consuming. I think Liz talked about this a bit yesterday, is that a big chunk of our intervention requires transcription. Right? So once we have done the intervention, we need to transcribe it and then put it into a legacy document. And the legacy document is really important, as you've seen from some of our comments, that it can be passed on to generation. So the time becomes important. Who has the time to do the transcription? And I think Liz pointed out something that's really important yesterday, is they have a whole bunch of volunteers trained as dignity therapists. I think we can really make use and nurture a community of volunteers that are writers, that can, or journalists, or whoever it is, and they can help us with the transcription, they can help us with conducting the interview, and that can put a lot of, that can eliminate a lot of the worries and concern of having, not having designated time to do FDI. Because I do understand that nurses, doctors, and physicians, they're very busy on a day-to-day basis. To add this on the workload could be something that's quite challenging. But if we have a volunteering group to do this, or even have a volunteer group to just do the transcription, because transcription, an hour transcription can take maybe 5, 6, 7 hours to be done. The quickest that we've seen is about 2 to 3 hours, but it's still a big chunk of time. We can compartmentalize it that way and have someone else to do the transcription, then the therapist can save a lot of time doing that. So that's the implementation part.
So I do actually see quite a number of questions asking about the practical issues of FDI. You know, who does it? Where can we do it? Is it free and things like that? So do you have anything to comment about where you see FDI in Singapore?
I think FDI, it's very versatile because it's really about a conversation. As long as you have the patient and family caregiver at the same place, it can be done at the home of the patient, it can be done on bedside in a nursing home, it can even be done on bedside of a hospice or a palliative care unit. In terms of the way to move forward, I think what we have been doing so far is the research we're at the last stage of the research. So we have the evidence to show that it works. The next stage is then to really expand this, to make this more sustainable, to make this more accessible to people. So over the past year or so, we have been offering FDI professional training through the Palliative Care Center of Excellence in Research and Education. And in fact, just last Thursday and Wednesday, we did the first ever virtual FDI workshop for over 36 participants. That workshop alone provides individuals with a more in-depth understanding of how to go through each component of FDI. But to be able to really do this, I think we need to be able to have consistent clinical supervision to ensure that you have someone to talk to, that you're supported in doing that type of work. So my team and I are more than happy to work with local collaborators. We're more than happy to provide that supervision to make sure that this is actually going to be implemented in the ground and to reach people. In terms of practicality, as I said before, it is time consuming. I mean, it does require a substantial amount of time. I mean, there's 4 sessions. But if you can build this into your clinical practice, if you can build this into one of the things that we offer to our patient, and instead of going to do your home visit, the home visit is an FDI session, then that becomes part of the program. And the third thing that I want to mention is, again, can we integrate FDI with ACP? I mean, we spent tens of millions of dollars in ACP, training up thousands of ACP facilitators and coordinators. Can we also train ACP facilitators to do FDI? So this becomes part of the whole process. And if you talk to any ACP facilitators, whether they're working in hospital or working in the community, they would tell you it is actually a very difficult task to engage people in medical decision making, to talk to them about, do you want resuscitation, do you want a feeding tube? They don't want to talk about these things. They're already worried about the situation. So instead of going directly into the medical care, can we spend some time talking about you and your relationship? And once the conversation gets started and you can build the relationship with the FDI or the ACP/therapist, then when FDI is over, I can smoothly move into a medical discussion. And I think that's something that we can really look forward to, and I hope that's where the development is going to take place for Singapore.
Okay, wonderful. So I think, Prof, we have maybe time for maybe perhaps one more question. So an anonymous attendee asked, well, if there are patients who are willing, what if there are patients who are willing to share their point of view on death, but their families and their caregivers refuse to accept their death and so refuse to talk about it? So how would we handle such situations, applying FBI to a family that's kind of unwilling to acknowledge this death discussion with the client?
Well, again, as I said before, it's FDI doesn't really talk about death unless it's being brought up. So within a session, I think we need to, and I think I need to also emphasize that FDI is not for everybody. You know, there are, if someone is really going through a really hard time emotionally, psychologically, they would probably benefit better from professional counseling or a therapist. FDI is a very brief, it's a very targeted and very structured type of intervention. And if the patient and the family caregiver are willing to engage in this, we sort of have this notion that they are ready to share about their lives. And if the topic of death comes up in the midst of a conversation, I'm quite more comfortable to believe, and from a clinical experience, that even though it may not be a comfortable topic, but when it's brought up in that supportive, nurturing environment, they may be willing to engage in a conversation about it. Now, Paul, you've been also in the, let me ask you this, Paul, because you've been doing a lot of FDI work with our patients in the community. Have this come across to you that patients want to talk about death, or the family want to talk about death, but they have, the other party never talked about this, and it becomes something that's awkward, or was it actually easily resolved in a session?
Okay, so from the number of patients that and families that I've worked with personally with FDI, there have been instances where patients and perhaps even the family members, mostly the family members, I feel, kind of afraid, unsure how to really broach this topic, don't want to talk about it. But as we get into really the core of the matter and patients start sharing and the emotionality is there, I think family members sort of have this deep sigh moment where they're just kind of like, okay, you know, I think it's time that I address this. So really, I feel that the role of the therapist is really to facilitate this, is to give caregivers and family members kind of like this emotional scaffolding and support, and a safe place to really think and talk about matters like this with regards to the patient. Yeah. So I feel that, yeah, like, as you mentioned before, Prof, the sensitivity of the therapist is very, very important.
Yeah, we definitely don't want to push people into things that they don't want to talk about, and we often need to constantly check in with them to see, is this comfortable for you? Do you still want to continue? Do you want to stop? So we definitely don't want to force people into a conversation they don't want to, but if this organically comes up and it seems to be, even though there might be a bit of discomfort, and as therapists, we need to be able to sit with discomfort. We don't just simply run away from it. You know, when the first challenge comes up, we don't run away. We actually sit with it and see how it changes, how it turns up. And sometimes once we are able to move beyond the first initial stage of discomfort, a lot of meaningful dialogue can emerge. So yes, death is still very much a taboo topic. There's a lot to be done in terms of public education, in terms of public advocacy. But even within the FDI conversation itself, when a death topic comes up, we don't necessarily need to run away from it. We just need to be aware, observe, be mindful, and see if this can be the golden opportunity, a teachable moment that we can engage our patients or our family into this conversation that needs to take place.
All right. Okay, I think, Prof, we are kind of a little bit out of time over here, so we've ran over just a little bit. And I do want to thank everybody so much for attending today's webinar. And, you know, thank you so much for attending. Yes, that's just, yeah, it's wonderful that, you know, for those of you in Singapore are up so early, you know, for those of you tuning in from all over the world, thank you so much for coming. And I hope you'll be able to join us tomorrow for Professor Robert Nehmeyer's webinar on meaning reconstruction and dignity preservation in loss and transition. So please do complete the poll in your pop-up window. There was sort of, when you leave, a little pop-up window, so don't get shocked. The little pop-up window will appear. So complete the poll and provide us with your very valuable feedback so that we can use that and incorporate them into future events as well. So thank you so much, and see you guys tomorrow at 9 o'clock. Right.
Thank you, everyone.
Take
care.